Good evening. This is nlcTrans. Thank you for joining us. I'm Stacy Dozier, and I'm here with my usual co-host and dear friend Renee Benoit. You may notice that Callie is not saying these words tonight. She and Tara are out of state, so you got us. But we have some special guests here from UConn. Jill Esplin has joined us, and she has brought some of her students to talk to us about their program at UConn. So this is where I make my own job pretty easy and say, Jill, would you like to tell us about your class?
Sure. I'm Jill Esplin, Dr. Jill Esplin, and I'm a psychiatric nurse practitioner. I teach psychiatric nursing, and the 4 students you see here, the nursing students, are in the classroom with me on the campus. And Kelsey, to my right, is also in my clinical group, as is Joanna. So right now, the students that are here with us are juniors and graduating in 2012. Okay. So they're really excited to be here. We're all excited to be here, and it's our pleasure really to be here. So
we're very happy to have you. So it's an upper level class.
Junior level. So right now they're doing the combination of psychiatric mental health nursing and medical surgical nursing. So we have the didactic classroom piece, and they also go into sort of the hospital, different hospital settings with psychiatric nursing and as well as med-surg nursing. So interesting semester for them to, it's an interesting time in healthcare too, to be out there in the community too as well. So.
Well, I'm very glad that each of you could join us. Maybe you'd like to tell us a little bit about the programs you're each in, I assume.
They're all in different clinical practicums or clinical, in the hospital. I say clinical, they could be in a freestanding psychiatric hospital. They could be in a hospital associated with like a medical hospital, a unit within a hospital. So I think, they can just kind of talk a little bit about their practicums, because I think right now there's a couple that are in this, maybe they're all in, yeah. So they can just talk a little bit about their practicum and where they are, and a little bit about their rotation would be kind of interesting.
That would be good. Why don't you start with you? Yes.
I'm Kelsey. I'm currently at Mount Sinai in Hartford, which is associated with St. Francis Hospital. I've been on 4 different units: the pediatric, adolescent, dually diagnosed for those that have psychiatric disorders and substance abuse issues, and then the general psychiatric adult floor. I really enjoy it.
I'm in that one as well, so I might as well add that right now. We've also had a jail rotation, which was really interesting, and we were able to see ECT, which
for people that
what are you
watching, what is that?
Electroconvulsive therapy.
Okay.
Which that was very interesting to see, and I don't really have a lot to add, except it's a great rotation.
Yeah.
Electroconvulsive therapy, what's that used to treat?
And Joanna, yeah.
Well, I mean, it treats a spectrum of disorders such as bipolar, anxiety.
Okay.
It's mostly used for major depressive disorder.
And contrary to popular belief, we still do that, and people probably think of the days of, One Flew Over the Cuckoo's Nest, or, they have this kind of idea that it's one of these, Frankenstein type, kind of scenario. But what it does is it's mostly for major depression. Person goes in for a series of treatments, and the treatment is that they induce a seizure within the brain, and it kind of realigns or makes available more chemicals, neurochemicals, so that the person is able to kind of, sort of pull out of the depression. And it's done in adjunct with medication usually. And when sometimes all medications failed, that's something that really works for some people. And very
So it's not a long-term thing, or something?
It is a long-term.
Oh, okay.
Yeah, it can be a long-term, because people might be on it for years and years, but it's ordered usually by a doc or a nurse practitioner that they may have treatment 3 times a week for a series of maybe up to 12 weeks, take a break from it, and then go back to it. So it's kind of like, it can be maintenance. Maintenance kind of, like you would a medication.
Sure.
And for those of the people that it works for, it's really excellent. I mean, people are actually able to get out of bed and do their activities of daily living, whereas before they might not have. So it's a lot of misconceptions. Media will show this what it kind of really isn't to really, but it's very safe and humane, and they do it at the Yukon Health Center, also at the Institute of Living.
Which is where Diana and I are
so
during our
yeah.
rotation. So we're at the IOL at Hartford Hospital, and I've had a really great experience with it. Just like Jill was saying, it's kind of one of those things I entered my practicum kind of thinking about these things that we see on TV with regard to mental health and psychiatric nursing and just medicine in general. And I have found out it's the complete opposite, and I've gained a lot of really great perspective working with a lot of these patients because they're it hits close to home. I mean, it's like anybody you know, so it's good to kind of have a good grasp of that. So.
I'm also at the IOL with Nisha, and I find that for me, I wanted to go into psychology originally when I was younger. So to have that ability to combine nursing and psychology is such a great opportunity. I want to actually consider getting my APRN to be a psych nurse, but I also enjoyed, we were allowed to go into the ER in the Purple Pod at Hartford Hospital and experience
Now, what is the Purple Pod?
it's the psych ER department.
Okay.
So all the substance abuse, people who are still drunk, the ones who come in who are their manic phases, you have all these people and they're just trying to stimulate them and bring down their stimulus. And I really enjoyed that. It opened up your eyes to other options besides long-term maintenance care for psych patients. It shows you how they get to that point, what they happen when they come in, when they're in their most vulnerable positions. So I thought that was really interesting too. We were able to experience that.
Yeah, because people think, psychiatric nursing is just kind of, or psychiatry, or some people maybe that have psychiatric issues, it's just confined to the psychiatric setting. But I think being in the ER, you kind of exposed to, wow, I have, people, everyday people have things that happen in their life, a lot of stressors, and it's almost, if we can kind of understand that, people that have mental illness or psychiatric issues, I mean, it's everyone. We're out in the community. People, and we can't really separate the two, say, oh, I'm just doing medical nursing, or surgical nursing. It's we're going to see the psychiatric piece in every kind of nursing, which is, it's really important, in our
That's
kind of
really so
curriculum
cool.
and our
Absolutely.
nursing education.
That's an interesting perspective, so that any nurse that is working with patients, you would want to have a certain sensitivity to the broader sort of mental illness issues that can be, or even issues that aren't necessarily a mental illness.
Right. Could be, just something. Someone.
We've seen lots of very young students who are in their college careers kind of overwhelmed with stress and family life in general, and it's something we all go through, and some cope better and some don't cope as well.
College is really stressful.
It's stressful.
Yes, it's
That's
stressful. I've
very
seen it from a number, from more than one direction.
Right.
We see it particularly in the fall semesters, especially with students freshmen. Students, if you really think about it, they left home, they're living in a new place, now they have all these
It's like a
credits.
combination of stressors.
Right, and then they can party.
Yeah.
So now it's just all this stress. So we really see that population coming in, and I'm sure you probably did at the Institute. If you had this semester, we see, over the course of the semesters that, wow, this fall semester is a big semester. But again, we can't just really separate it out and say, we see the people in the psychiatric setting. I mean, it's all over.
In my
It's just
med-surg clinical, that it's just at a regular med-surg floor hospital, I'd say about half of the patients have some sort of mental health diagnosis in addition to their, medical diagnosis. So having a background in mental health nursing is incredibly helpful.
because you're going to see that. And I think I read something. I don't know. I don't think I'm making this up. But it's 50% of people, just in general, are on some kind of psychotropic medication, whether it's for, depression, sleep problems, something. They're on
Absolutely.
anxiety.
I can easily believe that. I mean, just thinking about all the people I know with sleep issues, and some people will self-medicate, whether it's with over-the-counters or I'm fond of the Wiccan herbs and stuff. Weird, but yeah, I mean, just you think about all those different complications and the sort of the stress the economy can place us all.
Oh, yeah. We've heard that too. Like the ERs now is seeing a lot more people related to, just like anxiety, stress related, and we know that things that are manifested that way kind of show somatically. They might not say like, oh, I'm having a lot of anxiety. It might manifest differently, coming in shortness of breath, chest pain. So it's sort of a lot of the same symptoms.
A lot of people keep it in as well.
Keep it
and
in, right.
It builds and
And
builds
that's
and builds.
half the battle. It's just there's so much stigma even associated with going to get the help that you need.
Sure.
And that definitely deters people from going. And I've just seen anyone that I know just to urge them to go see a counselor. If you need some help, talking to
Right.
somebody is half the battle. Just getting it off your chest will really help clear things up.
Yeah, people should understand that just the recognition of needing help and needing to talk to someone isn't a weakness.
So the biggest issue is how do we resolve the economy? Right?
Well, I don't know.
I
Barack
heard
Obama. Is
Yeah.
Obama listening, or maybe the governor?
Sure.
Who knows? We don't know. But yeah, and like Nisha said, it's sometimes more acceptable to go to, to an ER or something and say, I don't really feel good. It's still that stigma that's attached, and people from maybe this generation is probably getting better, but generations like maybe like my mother's generation, they don't really say, I'm depressed or, I'm anxious. It kind of, it comes about in a different way.
Physiologically, it's sort of easy to see how that sort of long-term release of hormone can wreak havoc on a person's
It really
systems.
can. And I think you said, Stacy, people look for other ways too, and then we see that in the hospital too, where the drug abuse and the
Right.
alcohol use. Wow,
They
it's just
overlap
like,
so much.
It's so we see that, we call it the comorbidity or the duly diagnosed, right?
Yep.
That we see that they're just, it's unbelievable. A huge percentage of people that have some kind of issues, psychiatric issues, self-medicate with, alcohol or other drugs or your Wiccan drugs, teas and herbs. But yeah, a lot of times people do that. And
They're just trying to cope like the rest of us, and
Absolutely.
it's just some methods are easier than others and easily accessible, and so you have to really show an appreciation for where the person who you're dealing with is coming from, and respecting that and understanding that maybe necessarily it wasn't their fault, and there's a bunch of other contributing factors in their diagnosis. So being respectful
Right.
is a big part of it as well.
Absolutely.
I know, like, when I was in the ER at Hartford Hospital, there were patients that have been there, the nurses said 5 or 6 times within that month, having come in with alcohol abuse and whatnot, and they're like, oh, well, so-and-so lost their job a few months ago, and this is how they cope. And it shows you an opportunity, like, for you to use therapeutic communication and the ability to talk to someone and just offer them empathy and support,
Right.
which is something at this time in their life they need. And obviously they're not getting it in other sources, so it gives you a role as a nurse to feel as if you can give that support.
That's just
Right.
like there's a lot of the transgender people who are on hormone therapy. A lot of them, well, some that we know, self-medicate, and
Never a good idea, by
it's-
the way.
No.
Don't
Right.
take hormones off of medical supervision.
no.
It just
oh, you
just-
mean like just taking them, like, is it like black mark? What do you
Right.
mean? Like,
well, some
like,
of them will try to obtain the like estrogen on the black market.
or eBay or some
Or-
internet or
or-
You
something.
never know
Right.
what you're going to get ordering.
You never know what you're going to
Uh,
get. Plus,
That's the reasoning for the endocrinologist taking blood work, to make sure that the levels are where they're supposed to be. Getting them on the black market
right.
level is,
Well, I mean, yeah, there are a host of, obviously, there are a host of things that can complicate high-dose hormone therapy. Hypertension, I think,
Oh,
will
yeah,
do it.
definitely.
You can get pulmonary
Embolism?
embolisms
Yeah.
easily.
Absolutely.
They check for liver function. I had endocrinology done. And
Right.
it was, it's
What would make somebody, Stacy, go to the black? Is it because to
probably
go?
the fear of not being treated. Talking from the position of a person who's transsexual is the fear of going to a psychologist and them saying, "No, you're not transsexual. You're just weird."
That's the
and
biggest
we won't
issue.
give you the hormones. And it's sort of that desperation to fix your brain chemistry, really, that I think drives people to do that. I think they should, we have to work to help people to understand that when you get this endocrinology, they're not saying you're not transsexual or you can't transition. They're just saying, we want the treatment not to kill you. And if hormones aren't a possibility in one person's case, well, there are other treatments that are available.
And that's a hard line to walk. I mean, there's people who genuinely really need the psychiatric help and medication to really overcome their illness. But then there's other non-pharmacological sort of interventions you can use, and the support systems is where that sort of comes in. And being able to therapeutically, not in that way, talk to a patient and really kind of understand what they're going through and coming from is such a crucial part of care in the initial phases, you know.
So what would make the endocrinologist, or what is your? I think I don't understand. What's your first step? Like if you say to yourself that when you realize that yes, I really want to go through a change, and if you contact an endocrinologist, say, and
Well, your first step would be to
Therapy.
go to
Psychologist.
a psychologist who would perform a battery of tests, talk to you, and figure out where you're coming from. That psychologist would then refer you to an endocrinologist for testing.
so and then that endocrinologist might refuse to give you
Well, based on your
hormones, or
based on your test
It
results,
is
perhaps.
various testing that's done to see whether you're ready
Yeah.
for hormone therapy.
or see if it's healthy for you to take.
Yeah.
What designates it being healthy or that you're ready for it? Is there a certain level you need to reach in certain hormones, or?
I think really it's just a question of things that might counterindicate it, like hypertension might complicate high dose hormone
Yeah,
therapy.
or like risk of blood clots and things
Risk
like
of
that.
blood clots
Okay.
was one of the tests. Liver function,
Right.
that sort of thing. So they're really just testing to see if
Just your medical.
See if you can handle it then.
Yeah. They don't want to give you anything that'll cause harm or anything.
but
and if you do have some complicating factors and maybe you can't take oral hormones, I think now they're offering things like a transdermal patches, which
Right.
lowers the quantity that you have to
Right.
ingest.
That's good.
is that for life too now? Do you,
Yes.
do you take that for life?
Yes.
Have you found any medical consequences from being on long-term estrogen?
I think there are potential
Yeah.
long-term consequences. Some of those I think are lessened when if a person eventually opts for the gender reassignment surgery,
Yeah.
which removes the testes. And so you can sort of reduce the amount of hormones that you're taking.
Well, and I think what we're talking about here, right, we try to, as far as like our group is in the classroom and in clinical practice, we try to, understand, so we learn from each other, right? Because we have to learn from you, you learn from us. What are we doing wrong? What do we need to do as
a big
healthcare
help.
professionals?
Yeah.
Besides being empathic and trying to put ourselves in kind of your shoes and how we would want to be treated, we probably as collective would want to know, how would you, what kind of wisdom would you give to us as healthcare providers besides, being empathic and non-judgmental. What can I bring back, like, to my classroom and say to the students, you know, this is what sort of we learned from experiential discussions. You know, what do you think I could bring back sort of to the classroom too, as well? As just like maybe some issues that
You've
maybe you've
experienced,
encountered
yeah, with your
yourselves. Do you know what I mean? Like specific issues or things, because I know when we were at one of the hospitals, we did have a transgendered patient, and the transgendered patient kind of requested not to have, you know, nursing students, which that's fine. So I'm just wondering, you know, just because we don't really come across too many, and like it's not like an everyday thing that we would come across a transgendered patient, but
Could
we
it be fair?
No, I'm just saying, but if we did, I mean, and sometimes there probably is like a reaction because we're probably not used to it. Do you know what I mean? So just saying, okay, so if I had to teach that kind of empathy piece, how would I like teach it in the classroom? Do you have any like words that would come right from like experience, you know, like right that I could use? This is a personal.
Like, have you had any
Sort of.
encounters with like healthcare professionals that you found to be like helpful or not
distressing.
helpful? Yeah, that we can avoid.
That we can avoid, and we
Yeah.
can teach to saying, okay, yeah, this is what we see that, you know, works.
Well, I know that, I mean, the obvious one is missing pronouns is always, can be very uncomfortable and invalidating. I've been really lucky. People have either people have been really, really nice to me, or I'm so thick that I just haven't seen it.
Right.
But I think as you know, the generation changes, I think the time changes too with, you know, the acceptance, and it's much more acceptance today than it has been in the past, and I think it's becoming more open to everybody, where everybody feels comfortable with. It's not as bad as it used to be, is what I'm trying to say.
And I can't remember, my best friend was recently in the hospital, and therefore I was in the hospital with her. And that was a very positive experience with everyone we ran into, with every type of nurse who came in and doctor who came in and dealt with her.
I think that's
I think in
great,
this state, in this part of the state, we're very very lucky with our medical care providers. And
Well, I know, didn't Norwich Bacchus Hospital, didn't they have, well, I know last year they had this kind of like day of caring, where it was like in service for nurses that would be caring for transgendered patients, which I think that's great, but I've only seen that, I think at Norwich Bacchus Hospital last year. They had this, you know, kind of 2-day session for nurses. So I'm thinking, wow, that would be something really very good for the hospitals to do.
See, that's like I was saying, the education that's, you know, getting the word out there. It kind of helps a lot. And as our group is doing with the panel discussions at the local high schools and colleges, we have found it to be, you know, really accepting.
It really has. And so that brings me once again to the curriculum of your course here in psychiatric nursing. And so you teach students about various communities they will be treating.
Right. And so what's kind of exciting when you're talking about that, we were kind of talking in the car on the way over a little bit, and I think even last time I was on the show we kind of touched upon it a little bit. But we do, in the classroom, in the didactic piece, go over all the different illnesses and disorders, and we do some sexual disorders and just kind of sort of things that are, you know, I don't want to say sometimes gender, what do they say now in the DSM, gender identity disorder?
Right.
So it's kind of sometimes grouped into
Isn't
some of the
that
other
changing?
sexual disorders
Right.
as well, which is not, it's not really right to do that. So I know the
Right.
DSM, the new DSM coming out, the Diagnostic Manual of Statistics, it's sort of like the physician's desk reference for psychiatry, right? We look up mental illnesses, mental disorders. So I think that the new one coming out in the next couple of years, the DSM-5, kind of goes into the fact that it's really not, but it's
I think it calls it- I
incongruency.
think the
They
new
call
one
it
calls it an
Gender
incongruency, right?
incongruency, meaning, you know,
Yeah.
hey, I was born with the wrong, right.
Which is a nice change from disorder, which makes it
Mm-hmm.
It
sound
there's something
clarifies it a
Yeah,
little.
Exactly.
Yeah.
Right, so that's in the classroom, and even the psychiatric textbook I use, and any of the other ones I look at, sort of groups the gender now, this identity disorder or transgendered, in with other disorders that are kind of frightening disorders, that are these sexually, impulsive disorders, pedophilia, all of these, exhibitionism,
Yeah, they're all
fetishes,
grouped together.
it's kind of grouped together. So I think from the start there gives it sort of a negative connotation. So I'm really happy that I try not to teach it that way,
Right.
but that's the way it is now.
And some people people want to have it removed altogether.
But that would
And I have
run
to
into
really think about
problems.
that. That runs into problems because you sort of need a billing code.
Exactly.
Especially like,
That's it.
and your first, line of treatment is going to see a psychologist, and
Right.
why are you here if it's nothing in there,
Right.
Right, so, to just kind of keep it out of the DSM altogether, it's not,
It's not fair.
it's not fair. It
I
wouldn't
think
work.
eventually we may get there when society has less of a stigma against it. We have a way to go before we get to that point.
Right, because if you think of some of the other, I'm not even going to say other, but some of the illnesses, disorders, and other things now, even insomnia, things like that, that have been around for a long time, now are finally kind of losing stigma. So this, transgender, really, people were hiding, right? You really didn't
Oh,
come out
absolutely.
and say, I'm a transgendered person. I mean, maybe even a couple of years back, people would kind of say,
And I
wow.
think part of that, we do have a long history of hiding. I think part of that is we sort of inherited from medical advice that we used to get as a community. At one time, you were not allowed to transition unless the treating providers thought there was a chance you would ever pass. And so the idea was, your ideal path was that you would learn to pass and you'd sort of disappear. Well, if you disappear, no one sees you, no one learns about it, this condition, and nothing ever changes. And so I think our process of sort of educating the public was hampered a little bit by that, was slowed a little bit by that. And so now more and more we are having people willing to come out and educate people, which is nice. And we do have a phone call.
Wow.
But yeah, I know who that is.
It's my mother. Hi, Mom. And Putnam. Hi, Claire.
Good evening. Welcome.
Hi, it's nobody's mother. It's Kate.
Hi, Kate.
Hi there. Nice to see you all, and what a very informative program. It's
Thank you.
A pleasure to see something with young people interested in going into nursing, learning about what you're going through and not calling it a disease. Because I think it's just, it doesn't fall in that category at all. It's just something that's there that's inherent, and you have to learn to move on, and if the medical community can learn that as well, I think everybody on earth will be better off.
Yes.
I agree. Thank you very much.
Thank you so much, Kate.
You're welcome. Have a great evening.
You
You
too.
too.
Thank you.
Bye-bye.
She's so sweet.
How nice, and that is nice, because we look to the next generation really to set, to kind of lose less and less of stigma. So
a
I think
change.
it's, make a change.
And I do see that with the younger people. You sort of see as with the younger people are generally more accepting. They've seen it.
It doesn't seem to be such a big deal to the younger generation. It's just an everyday thing.
A friend of mine, I met her just a month ago, but in December, her 7-year-old child, who's born anatomically female, said, "You know what? No, actually, I'm a boy." And her answer was, "Okay, give me a hug."
Oh,
And
yeah.
see, she had met
Yeah.
transsexuals, and she knew all about it. But her child's friends are very nonplussed by
Yeah.
it. Just, this is normal.
Right.
Absolutely. I've seen a couple people young, like age of 4 years old, and they will tell you, "I'm a girl," and they're, born a boy, but they will tell you from a very young age. I think it's very much something you're born with, and
I think it's wonderful that people can come out younger.
yeah.
It saves decades of pain.
Yeah, absolutely.
That must be awful, really. And I think, coming from a university, one of the bigger universities in our small state, I think UConn does a really good job. I'm not really promoting the university here, but does a really good job with
the championships.
the
That's
championships, right? Yeah, we get the #1 spot for the men. And probably women should have, but I don't know what
That's all right,
happened.
we won't talk
We
about
won't
that.
talk about that. They did a good job all season.
They
but
did.
we have didn't something just happen on UConn? Where they had the overnight, the Rainbow Center sponsors that,
Yes.
wasn't it a big thing at UConn? What was it? The
Oh, True Colors.
Yes.
Yeah.
True
True
Colors.
Thank you.
All of a sudden, camera shy. But the True Colors, and so I think it really promotes as a university, and we have a really strong Rainbow Center, and just kind of, so, I mean, that's good.
Floretta King is one of the greatest.
Yeah, Floretta's great.
Just don't get a hug from her, because you'll never survive it.
Yeah, she's
She
great.
is super.
She's great. So we
Yes.
do a lot. I know you do a lot, too, through the Rainbow Center on campus.
Well,
And
we really enjoy talking to students, and it turns out a number of your classes invite actual transsexuals to come in. and
that's
talk.
great, yeah, because you'll be on a panel, hopefully, on next Monday,
next
coming into
Monday.
the classroom to speak to our classroom. And I think sometimes that's where the true learning is. I mean, we can read in the textbooks, and just to have a panel, in front of us, I mean, well, how great is that?
To hear like your
Yeah.
lived experiences as opposed
Right.
to reading about like the clinical side of it.
Now,
Right.
did you know about this panel before you took the class, or?
The transgender that comes
Yes.
in? No.
I don't.
No.
I don't know if you work with athletics, but I know, especially in athletics nowadays, they've become a lot more open with having communities and groups that help. Like, I see in our athletic study lounge, they have posters and they have hangers and like different signs for different community like support groups for the gay and lesbian population and the transgender population in athletics, because I think that's also an issue that was always masked for a while. People assume some female athletes always like lesbians, they stigmatize sports and whatnot.
Oh,
So
right.
they've offered support groups
Geez,
for that.
that's interesting.
and
I
communities for
never
that,
thought
too.
of it that way, but it is true. Yeah.
I know, that's great.
Yeah, that's awesome.
It ends up always only being about communication, right? As long as somebody's willing to teach us and talk to us, then we can, help shape our practice and our nursing, judgment in the future. So it's as long as everyone's willing to, come to the table and have the conversation.
Well, I think it works both ways.
Yeah.
I mean, as well as us, in communicating with the classes and stuff. And
There's an interesting exercise I often talk about. When you're sitting, and it takes some getting used to try to do it, or it did for me. So when you're sitting there and you're taking questions, if you think about it, you can learn as much about the questioner As the questioner learns about you from the nature of the question that they've asked, then you know what's important to that person, and if you can draw a little bit more out of them. So what did you mean? And
Right,
So
right.
you can. It's an interesting and rewarding sort of an exercise, I think. I really enjoy. I've always had a positive experience. I'm talking to students at UConn and Mitchell when I've done that.
Me as
And
well.
that's where we learn, you know, that's how the students learn and this is what we do when we're in the clinical setting. You know, if we look at sort of like the medical model, right, and some nursing is going towards the medical model. I'm not knocking the medical model because we do need it, but it's more focused on, you know, like cure and medications and, you know, us, nursing, and particularly psychiatric nursing, we focus more on the person and the communication and just trying.
It's just more than
Right.
just the surface.
Right, and just getting like from the person, like your lived experience, and that's how kind of like we really learn about things, about the person that you're caring for. You know, it's just not like if we say, oh, it's the person down the hall with the heart attack. You know what I mean? It's just like really kind of sort of takes the person out of
cold
it.
and
It's the heart
impersonal.
attack, right? So we try to focus, and that's what's so great about having you come in psychiatric nursing. We really just focus on, you know, using yourself and talking to the person, getting the communication going, learning from them what's
So
happening with them.
hopefully you'll all have questions for us when we come in.
Oh, we will. We will.
Stock up on 'em.
We'll have a lot of questions, and like last year, it worked out really well. You know, the students had a lot of questions, and the panel was
There
great.
was one very interesting question last year about the pet. Remember?
Oh, about the
if-
cat.
Oh,
The cat?
yes.
Was it a dog or?
One of the students asked
Yeah,
about
oh, yeah.
how the pet accepted it.
Accepted the transition.
Right,
Transition.
right. Was the pet? Yeah.
That was really interesting.
Yeah.
We've never been asked that before, but it was.
It is,
So
because,
it's-
you know, I think to myself, wow, that must be kind of like either a relief for you or just like something that is just so incredible. You know what I mean? To just do that, I mean, my hat is really off to people that finally just say, you know, I have to do it. You know, and then you don't care about what people think because this is really you.
Well, it's a big burden
It's a big-
that's
Lifted.
You know, I mean, it's unbelievable, the before and the after. To go on living your daily lives as normal.
Right. I mean, that's true. And for me, it was very much a situation where I was choosing to live. So, I mean, I wasn't going to be around much longer if I didn't do it. So,
We talk about quality of life all the time. There's
Right.
the medical quality of life, the psychiatric quality of life,
Sure.
and we throw that term around so much that I think sometimes you really have to get down to communicating with an individual to
Right.
really understand that. And I think we maybe should be asking ourselves that question more and communicating better.
one thing that I always like to make sure we communicate to students before we get up and talk is we are notoriously difficult to shock.
Right, yes. I remember
true.
that, so, because you had some good questions.
Bring them.
Right, you had
Heard
some good
everything.
questions.
Yes.
Nothing will shock you, right?
Once you're in
Be
nursing school,
prepared to get an answer.
Right.
you can do with the answer.
Then you can ask the question.
As a matter of fact, when was it last year? Tara had challenged your class for more questions. One of the classes. I'm not sure which one it was, but
Yeah, and I'm not sure.
But you know, some students are still kind of shy. So I think last year, they are to even like speak in front of a, you know, because the class is pretty big. It's like 60-something.
well, what we found it to be
So-
in a lot of the panels we've done is that we tell our stories and then we leave it up to the students for questioning. And then, you know, at the very beginning there'll be like one or two questions. And then by the end of the class,
Everyone
everybody's raising their hands. So it takes, you know, everybody comes out of their shell
I
eventually.
think once or twice Tara has had a list of things she thinks people should have asked, so she'll get people warmed up to it.
I think it's good.
Yeah.
That's good.
Here's one that might have made us uncomfortable, but didn't.
Well, I think last year too, I think we collected some pre-questions because, and I knew like, okay, just write it if you're kind of like one of those types of students that you don't really like to raise and talk in front of, because some people are sort of, like that. So I just said, put them on a piece of paper and we gave them to you.
Yeah.
And it was just anonymous, okay?
Right.
So, and then
That's a
it's,
good idea.
yeah, and then it
Anonymous.
spurs more questions like, oh, they asked that question, so
Now I can ask
ask
this.
this. I don't feel
Oh,
so.
that was fair.
Yeah, right. But I think like on the way over, we were talking in the car too, and we were wondering, like, the way the healthcare system is and how, is like when you decide to kind of, I need to really maybe go to a psychologist or something. Is it covered by, what's covered? We were just wondering that.
What's covered what?
by
If you're
insurance?
in a big company, Fortune 500 company, they expect you to be under a lot of stress very often. And I think most of them provide a helpline. And you can, in fact, call that and get referred quite easily to a psychologist or a psychiatric health professional. And it's covered. It's like you're saying, doctors copay for however many visits it ends up taking. But I'm not sure otherwise for smaller companies.
But how about, what about the
The
other
medical procedures.
medical procedures and that's not covered
It's
right
not
now,
covered.
right?
Some companies are covering the gender reassignment. More and more companies are. The bigger ones are beginning to cover it. And they're seeing that, I think in the past, there was this concern that, if we start covering this, they're going to come out of the woodwork, and this is expensive. And, no one signs up for this unless it's
Right.
absolutely necessary. And they're seeing that with transition, they get much better employees.
Happier.
So more and more
Right.
they're seeing it as a positive diversity step to say, yeah, we're going to cover this. It's not going to kill the budget overall. It doesn't happen very frequently. So I think that trend will continue.
That's good.
That is good. That was something we were thinking because we were also talking in their clinical rotations. I think Joanna and Kelsey, both of them had been to the jail. And I don't know if you
Yeah,
the
you've been
Department of
pretty quiet
Corrections.
tonight.
Camera shy.
But we were
Gotta break
just,
you of that.
I think we were talking about that too as well, because I think was there somebody that was transgender, transitioning?
Not while I was there.
Not while I was there.
Yeah, because we were wondering, like, wow, that must be tough, because they were in a jail that was all male.
So how was that?
So, we were just wondering, like, wow, if that must be really difficult for someone that, an issue.
Fatal, sort of. So a male to female transsexual in a male jail.
Yes.
That could be fatal
Yeah.
if they're kept in general population, and if they're kept in isolation, that's potentially cruel.
Yeah.
Is there some kind of law about?
Don't know.
Yeah,
I don't
we were
think so.
just talking in the
Like, does
car.
it matter like how far you are along into the transition, or?
It was a
I
Law
think
and Order
post.
episode.
I saw that
It
one.
was a Law and Order SVU, Special Victims Unit.
Oh,
They
okay.
actually had it where it was the the male transition to a female, but they were in the process and hadn't had the surgery yet. Therefore, they put them in the male prison, and I'm pretty
Right.
sure.
Well, they would
And
put
sure they
them
were
in
murdered.
protective
Yeah.
custody.
Yeah.
Mhm, but
I
the-
That's what
assume
they
it
were-
was protect. Yeah.
In the
Protective
show, it ended up
custody.
having them being murdered at the end. That's how they showed it.
Hopefully.
It's just like
Yeah.
it opens your eyes up to that whole issue almost.
Things you might not
They,
think
they,
about.
they
concern.
wouldn't combine them together. It would be protective custody.
Yeah, which would end up, I think, if I'm not mistaken, it would amount to solitary confinement.
Right.
Which is
But that's
considered
Equally as
cruel,
bad.
which is
Yeah.
cruel.
that's why you
Right.
can't leave someone just because it's something they can't control.
Yeah, so we were talking about a lot of different things in the car, thinking, oh, wow. You know, it's kind of really opens somebody's eyes, like us,
Yeah.
into, wow, what a lot of different issues that you must face, you know, going through the transition or before you go through the transition, and even just basic things, even if you're in the hospital.
Well, when
You
when
know?
you first come out, I mean, you're looking over your shoulder constantly, at least I did. I waited till 12 o'clock at night to go and get gas in another state. And then even there, I was looking over my shoulder to see if, you know, it was so obvious, but now it's just routine, and it's like, don't think anything of it anymore. That's
Right.
my experience with it.
Yeah, my first time out was in Burlington, Vermont. A friend of mine had moved there, and she was the friend I told first with a few months previously when I was really at the low point. And I told her 3 times, and she just blanked me. And I thought she wasn't understanding it. She said, no, it's fine. And she was the person who accepted me and sort of made it okay.
Yeah.
And so she had moved up there, so I went up there to go out the first time. And after that, I realized it was going to be fine.
Wow, that's, yeah.
We got 4 minutes. 4 minutes left.
Okay, so some of the other communities that you work with, have you had any other groups come in and talk, or?
So far, yes, we've had this really neat program that well, it's a different program. It's not really like a group of people from a certain community, but sort of. We had a simulation of what it would be like to have schizophrenia, which is kind of interesting.
Wow.
So they were in, just last week,
Yeah.
they were in the simulation of, you know, wearing the little, like a pack, or a programmed pack,
Yeah.
MP3
Yeah.
player or something, with the little headphones, and in the headphones it was simulating
Voices.
auditory hallucinations. So they had to do that for, what, an hour?
Yeah.
Or
And then
2 hours?
Do tasks while
Oh, no, it was
those are.
hard.
That
It was
must have
nothing
been
like you
difficult doing
expected.
it
Yeah.
for an hour. It's
Yeah.
like, wow.
I
So to
can't
bring
imagine.
that
Yeah.
kind of understanding of how is it, you know, when you're having to care for someone that has auditory hallucinations. So that's a whole population in itself too, you know, so you can tell, I mean, that was like, that was really kind of a good experience.
Yeah, I wish we had more things like that simulating like what it's, you know, because it puts us really in their shoes and to see what it's like. So it'd be interesting to see in different populations kind of living in that way.
We also recently had a speaker come in to talk about anorexia.
Oh, right.
And it's
Yeah.
kind of an interesting topic because, you know, as a population, college students and younger struggle with it all the time. And we always see these images of these emaciated people who they just don't look healthy, and obviously they're not. But it was really great to put a face to someone who had survived the illness and was continually battling it. It's really great to just kind of understand all of the different things that she went through and that she's currently dealing with now.
That's awesome.
Yeah, so she was dynamic.
I am watching the clock. They don't think that I am in the control room, but
do
since
2
Kelly's
minutes,
not here,
1
I
minute
thought
left.
it was my responsibility to make sure we go right up to the clock, because
Yeah.
often they come out with the hook and they have to tell us. So we've got 1 minute left. We look forward to coming to talk to your class. Thank
And
you
we're
so much.
hoping that you
Thank you
can
so
come
much for
back
having
and,
us.
because we have a lot more questions we'd like to go over with you. So we'd love to have you back.
We'd love to have all of you back, absolutely. Look forward to talking to you next week. Next week, Callie and Tara will be back. Don't know who our guest will be, but they'll be awesome. So I think that's all for tonight. Yep, we're off.
Bye.
Bye, Mom. So we're all done.